Next up, we have Trishan Panch. He's a medical doctor and health technology entrepreneur. He serves as a lecturer in health sciences and technology at MIT and leads the team at Sana Mobile, an MIT-based research group working to develop mobile health technology for developing countries. Trishan.
There we go. Right. So I'm Trishan. Nice to meet you all. It's been a great conference. I want to thank John and Clark and the rest of the Health Map team. I'm going to talk about something a little bit different. Firstly, about our work with Sana. Not so much about global health, because Hamish is after me and he knows a lot more about it than I do. But specifically about kind of what we learned developing an open source telemedicine platform that we implemented in developing countries, and how we've taken some of that and we're looking to look at the problem of chronic disease here. And I think in digital disease detection, although the detection element is not as much of a problem, although there is a large proportion of people with chronic diseases who are undiagnosed, but particularly in the concept of there's a lot of people also who are undertreated, and what role is there for technology and some of the approaches that we've heard, particularly feeding into persuasive technology innovations from other areas. And I'm going to talk a little bit about that in the brief amount of time that I have. So, yeah. Right, good. Yeah, I don't know what's going on. So, it's first I'll talk about Sana, and then I'll tell you a little bit about the challenge of chronic disease and some of the insights that we've had. So Sana is a multidisciplinary research group at MIT. We developed a couple of years ago. Clark and a few other engineers got together with a few other doctors, including Hamish and my good friend Leo, and they developed a open source cell phone based telemedicine platform on the Android platform. The kind of analogy was OpenMRS, which is the work of Partners in Health and Regan Streif, was an open source. I'm just going to screw this up. Okay, telemedicine. Was an open source e-health platform. Basically an open source EMR for use in developing countries. And we looked at using what was then new Android smartphones to extend the reach beyond the clinic. So particularly for the kind of verticals of disease screening, but also with a view to moving into disease management. It was done and set up from the start and continues to exist solely with a group of volunteers, a distributed network, lots of us here and in and around Boston, and then also internationally. And what we have learned from that is that the technology piece is one small, this is kind of obvious, right, to anyone who's done development, that it's not just a technology problem. And we've done a lot of work, and a lot of work is going on literally kind of as I'm speaking. There's a course at MIT that Hamish and Leo were instrumental in setting up, which is looking at information systems with it through the lens of quality improvement in resource-constrained settings, and what the role is of information systems and what best practices can be learned from other areas in terms of... wow, I don't know what this is. Right, anyway, it's... okay. So anyways, good, okay. So, Sana has been implemented in lots of places. It's cool. It's in lots of different areas. I'm going to leave it like that. One of which was where I was this summer, which is e-health points in India. Now, this is not a fairly typical implementation of what we did now, but I think it indicates a few points. It's just easier to explain this way rather than just me prattling on. And basically what they wanted to do, this is Ashoka. It's an Ashoka-funded project, a social and entrepreneurship project where they're looking at the problem, particularly in India. There's lots of places where there's rural villages where they've gone above subsistence living, particularly in the richer states, the northwest, some in the south of India, and there's a growing burden of chronic disease that's not addressed, of non-communicable disease that's not addressed, as well as the classic paradigm, this classic triple burden that's developing. Now, although India is enjoying double-digit GDP growth, every year hundreds of thousands of people are entering the middle class. The public health system is not, and some could argue there's no real precedent for being able to scale quickly to satisfy that need. So there's, in that space, a lot of different organizations, loads of them public-private partnerships with mixtures of business model, like the essentially grant-funded with some fee-for-service, are trying different pilots and experiments. And eHealth Points is I'm not necessarily advocating the best or the worst. In fact, I think they've got a lot of innovative practices, and there's a lot of other organizations like this. But they approached us to work with them to try and look at going from setting up these clinics, which are a mixture of, that's not what I wanted to, are a mixture of basically a classic clinic with a pharmacy and a reception area, where you can see that's not the slide I'm seeing, okay, that's where you can see a doctor in residence, or if the doctor's not in residence, via telemedicine. And they also sell clean water. Now, what's interesting is that, well, they're not entirely kind of related, but I think it's an interesting point. So in these clinics, the reason they've been able to gain traction is nothing to do with the health stuff, which is very underutilized. Now, it could be because people like the face-to-face interaction of seeing a doctor, even in a rural area, and it could be quite reasonably this is a rural area that unless something is, it bleeds or it causes you breathing discomfort or you're in pain such that you can't do your other activities, you don't really think about it. And certainly, like, from my kind of work there, that's what I found, really. Like, this kind of, it really is kind of almost a religious belief, or that's the wrong word, but like a quasi-religious belief in, that you have to have, that stuff that doesn't cause you symptoms now is going to cause you problems in the future. And there's a lot of awareness that needs to be built and public health education to enable that to exist, and it just doesn't exist in these areas. So unless something is an acute problem, they won't come and see someone, and if they do come and see someone with an acute problem, they expect an acute therapy from the studies we did with these populations. But what they have had a huge amount of traction in is in clean water. Now, they give out, so one medical consultation, either by telemedicine or in person with a physician, costs the equivalent of 50 cents. For the same price, you can get 1 month, for 1 month, you can get 20 litres per day, per five people, per family, of clean water delivered. So, I mean, that's a very, very interesting, obviously, so this is scale, there's no real alternative, it's either this or well water, and this is of the quality of mineral water, and they've been able to produce these water points at scale and fund them from internal revenue, and they're trying to make the health piece work. And they're trying to go towards more scheduled care, scheduled evidence-based care, rather than just walk-in care for kind of minor self-limiting ailments predominantly. So the reason I bring that up is kind of what we learn from that. I mean, there's a lot of things, but the headline message is that kind of the technology piece is one piece of it, and it's within the context of lots of other intersecting public health measures, which is kind of not news to anyone, but it really started me thinking personally. And as a primary care physician, I had a population of patients in London before I came here about the problem of chronic diseases, and like what in this generation, in our generation, like, what are the innovations that are going to need to, or what are the problems that are going to need to be addressed. So I tried to put this is just kind of what we're thinking about. It's definitely not an exhaustive list. There's lots of stuff on here that can be gone into greater depth, but some of the work that we're doing is, obviously there's the socio-economic factors and the environmental factors, obesogenic, and you can extrapolate that to other high-risk health behaviours. But also there's the kind of fundamental problem of this externality. There's short-term behaviours, or short-term things that happen to you now, that you do now or are done to you, that have an aggregate effect on creating disease in the very long term, 10 to 15 years in the future. Now, it's an amazingly abstract concept. It's even in systems like in the UK, where we've got a free single-payer health system with relatively high-quality primary care, very high quality, I guess, in the kind of international context. It's still very difficult to get people to engage with preventive therapy and preventive medicine, and then especially so even once the diagnostic piece is taken care of, and now the actual schedule of primary care for chronic diseases is fairly standardized, and the recent 33 quality metrics as part of the new quality contract here in the US has a lot of similarities to what we did in Britain with quality and outcomes framework. But still, there's like a massively long feedback cycle for any chronic disease. You have an appointment, most patients will see on average a doctor once a year, and in between that time there's behaviors both in the positive and negative dimension that are occurring and not getting any feedback till the next time that person's seen. So there has to be something that looks at this long feedback cycle and is a kind of a force, it's a crude analogy, like is a force multiplier and multiplies the effect of the existing primary care schedule, which just won't scale to a greater burden of chronic disease. And secondly, there is the concept of risk. Kind of fundamentally underpinning this is like a population-based estimate of what is likely to happen applied to an individual, and it's an event that occurs a long time in the future with a massive steady state. Now, it's really difficult to engage people in that, and I think like these are some of the areas that like are ripe for some innovation from a technology and public health point of view. And in particular, one of the things that Health Map started me thinking about, and John and Clark and I and others have been thinking about, is health GPS. So like, you know, it's not just kind of where you are, but where you need to be. But I mean, that itself is crude. That's the kind of risk, that's the population risk as applied to an individual. But even more specifically, something that iteratively responds to kind of where you're going and guides you back in the right direction. And I think kind of, if it's not stretching the analogy too far, it's kind of thinking also that, you know, and it's kind of classic with health coaching or the practice of medicine, you're trying to train the person to think this way for themselves. So some kind of guide is useful. And I think there's a lot of room for innovation in that, and I think it's going to be a piece of work not just for our group, but for lots of different groups working together over. It's kind of thinking about a vision for that, and then I'll kind of finish. Is you know, I mean, in the future, kind of at some way in the present, you know, the future is here. It's just not evenly distributed. In the presence of metadata around our lives, some of which can be captured from social networks, and we heard a lot about that yesterday, and some of which may be captured from commoditized distributed sensors, for example, in our clothing or cheap devices aggregated on the phone due to the work of people like Amol, who's going to speak next, and as inputs into predictive models. This concept of risk really needs to be reframed. We're looking into ways of kind of using the inverse principle, a resilience, like the equivalent of kind of like a shield or a defense in a computer game, you know, something that defends you against the insults that can be incurred from the environment. Feedback that is more proximate, more tightly connected to index behavior, and basically also addressing the dimensionality problem. Like anyone that has a chronic disease has to do stuff in, you know, whatever disease it is, to optimize your health potential. There's stuff that has to be done in different dimensions, you know, turning up for appointments, getting tests, keeping them in an acceptable range, taking medication, changing an index behavior, you know, eating less, exercising more, smoking less, kind of thing. Those handling activities in different dimensions simultaneously with different feedback cycles is inherently difficult. So a few of us are working on carving off a very small piece of this with this thing that is called One Health Score that we're going to have a look at releasing next week on using the Runkeeper API to take objective data from phones as an input into a predictive model that my friend Jake, who's another epidemiologist, did as part of his PhD, and that will be online next week. But in the interest of time, I'll finish, and just contact me if you want to talk. Thanks.